Good afternoon, everyone. So I'd like to thank Teleon for the kind invitation to talk in the symposium. So I'll just give you some overviews about the lenses that are available and some situations where I use this lens, and I'll show you some clinical examples from this itself. And I'll explain to you why I basically use this platform for this technology. So let's just go back a little bit. Okay. So Harold Ridley, of course, was the first person to implant an intraocular lens at St. Thomas's Hospital. I was lucky enough to be a medical student there, and this used to be outside the halls of residence where I used to basically live. And if you look at the initial outcomes from the surgery, you know, the residual refractive error was quite high, right? You can see almost basically like minus 20. Some patients had to go a lens exchange. The second patient had to undergo a lens exchange as well. And of course, we've seen massive improvement from that first surgical procedure that was basically done in 1950. In the 80s, of course, we got better with IOL constant powers, but you can still see about 5% of patients almost have greater than 5 diopters out from the optimal, basically, outcome as well. And we've seen successful improvements on accuracy of our cataract surgery, and we've seen this with improvements in intraocular lens formulas, and we've seen this from multiple audits. And the idea is that now cataract has transitioned from a therapeutic procedure, which is what we were probably doing in the 80s, to much more to a refractive procedure now, where we're trying to push the limits of what we can basically give our patients. So it's no longer the fact that I can put a lens in, you can wear a pair of glasses, and you can see well. The concept has basically changed now, and we're really pushing the barriers basically to be able to push this limit of what we can actually achieve. And in order to do this, you need to have an accurate formula of a calculation of where your basically lens is going to basically sit itself. And you can see that from single formula optimization, which a lot of us basically try to do. You know, 1% of people can get about 92% accuracy within half a diopter of basically of accuracy. Now, if you look at the errors in basically outcome of when you're basically doing standard intraocular lens surgery, you will see there are two large areas that basically gleam over here. So one is the axial length measurements that have improved with optical biometry. And the second is basically your capsulorhexis. Now, of course, as Sheetal basically has shown you, now there's massive technology to improve your capsulorhexis. So if you have access to a femtosecond laser, of course, you can eliminate this down with supreme levels of basic accuracy. And optical biometry is certainly basically improved thing. So if you look at the other big area, this leaves your basically IOL, basically, or IOL calculation to where you basically have the largest area of inaccuracies when we're looking at this. With respect to IOL inaccuracies, what we're basically all concerned about and try to improve is our effective lens position. So if you can predict your effective lens position after surgery, you're going to know exactly how to calculate your biometry. And there are lots of reasons which I'll show you why this is going to basically be difficult to do when we're putting lenses in the bags. All of these factors we know are going to affect your basic ELP. So you can do a lot of work on formulation, and the new Barrett formulation, which is what I use for a lot of my surgery, is very, very good. But that you still get a standard deviation and a variation. And all of these parameters have to be much tighter if you're doing premium IOL surgery with a multifocal or trifocal technology. But you cannot have that standard deviation in your outcomes because your patients are going to be unhappy because they paid for basically better surgery. This just shows you two patients of mine I did recently, and Dennis captured this for me from the ZA. You'll see these two patients, routine cataract surgery. Look at the difference in the thickness of the bag from one side to the other side. And we never look at bag sizes at all because we don't basically measure it. You basically measure this with a femtosecond laser when we're basically removing the lenses, but we never consider the bags when we're putting lenses inside the eye because what we're trying to do is not break the posterior capsule and put the lens inside the bag itself. But clearly, if you have a larger bag, you're going to basically have a different effect with a lens that's a 2-base or a 4-base haptic than one basically with a smaller bag. And it's going to have a difference on your outcome. And you can see this with the AC depth basically on the left-hand side compared to one basically on the right-hand side over here as well. So you've got to think about this when you're putting your lenses inside the eye and how this is going to basically affect your patient. And I'll show you this with an example here. So this is a 68-year-old lady who basically had blurred vision in both eyes, so she has bilateral cataracts. No past medical history of note, so 3+ NS cataracts. Basically, frontal examination was normal. One of the trainees basically did a left eye phacoemulsification, put a good lens in, a Zebu lens and stuff, and got a pretty good visual acuity result. Okay, day 1 vision 67.5. At 1 month when she came back, she was complaining of photopsia and a streak of light around basically a light source. Now, her best corrected visual acuity is pretty good. The streak was still present with basically full correction, and she complained there's no difference with basically good lighting or basically poor lighting, so mesopic or basically scotopic. So as most trainees will do, they say, just wait, come back in 3 months, see somebody else. So they basically brought her back in 3 months' time, hoping somebody else would see her. Unfortunately, she went back to the same resident, and he basically complained about the same things, right? And she's not a demanding patient. She's just basically complaining she's seeing basically a streak. So someone else more senior basically saw her at that time. They said they thought that she may be having some aberration basically problems. They weren't really sure of the cause, but this is a good lens. It's an aspheric lens over here that she put in. And she refused to have surgery in the other eye with a 3+ nucleoscopic cataract because she was worried that she was going to get the same thing in this left eye. So then they basically sent her to my clinic to basically have a look. And what you can basically see is now 4 months post-ops, you can see this streak here on the retroillumination is much more easy. Much difficult to see on this side over here, but you can see basically on this side as well. And I looked at basically the aberrations. You can look at the topography, maybe some little bit of steepening on the side over here, but essentially her spherical aberrations and her coma essentially is exactly basically the same, and corneal astigmatism was same on the surface itself, okay? So basically I spoke to her. Luckily they didn't yag her, and I said, look, this is the situation, basically, and I said this is probably related to the size of your capsule when you had your cataract surgery. This is a 2-foot plate lens, and basically it's not stretching it out enough, and the capsule's now got basically a crease over here. So I wasn't 100% sure whether it was a capsule here or basically whether this was a fold in the lens or the lens was damaged basically during the lens insertion. So anyway, what I did was I took her back to OT to have a better look, and in fact, actually, this fold was actually in the posterior capsule. So I moved a little bit with the crease by adjusting basically the lens position. And when she came back, she says she sees basically better. You can see the large fold is gone, but she does have some little folds basically on the side over here. And now she said after repositioning, she now only sees it basically at light. So I said to her, look, don't worry, I didn't have to do a lens exchange. I can just basically yag this basically later on. But now she knew that there was a problem because we found out what the issue was. So she said, I'll tell you what, let's go for the other eye surgery. What are you going to do for that side? So I said to her, well, okay, let's avoid this situation completely, and let's clip your lens basically to the anterior capsule. Then I don't care what size your bag is because it's not going to make a difference with my surgery. So typically I'll use the Z8 for the cataract surgery. So as Sheetal mentioned, you can have different variations in the height. I use 400 microns basically for my settings for your anterior capsule, and you'll get a free-floating capsule pretty much every time. And for the corneal incisions, typically they will program 2 for me, 1 either side, basically when I use this basically lens. So you can see this is basically just lifting up basically the capsule viscoelastic, and then we basically take the lens out basically in your normal manner. And then what we'll do is that once we basically put the lens in, inject it basically into the posterior, into the capsule. And typically when you're basically injecting the lens in initially, I sort of inject it and I wait a little bit and allow it to basically open by itself. So this is the lens. I check to basically make sure the haptics are basically on the anterior side. This is an injector that we got from Swiss Med and Transmedica that gives to use the lens with itself. So I'm just checking to see make sure the flanges on the anterior surface, which is important to basically check that. Then gently basically put it in position with the OVD in place. And then you see I inject and I just wait and let it basically open up by itself. Now once the lens is basically in the capsule, what I then do is that I will then remove the viscoelastic, and typically I will use a cohesive viscoelastic basically over here to make sure I can get all the viscoelastic out from outside, from underneath the lens itself. And I have intraoperative OCT and OT as well. And I can check to make sure the posterior capsule has collapsed basically behind the lens itself. So you can go underneath the lens, or I can just gently rotate the lens. Then I put a bit of viscoelastic on the anterior surface. Now, if you do bimanual, of course, you can just put an irrigation in on that side. And then you can see I use a side port that's created with the laser to flip up the haptics basically over the anterior capsule, typically starting with the larger ones first of all, and you can rock it either side and then basically do the smaller haptics on the surface. And all of these capsules that I will show are all being created with the Z8 femtosecond laser. You can do it manually. I have done it on a few cases manually, but you have to be very accurate with your centration basically when you're doing a manual capsulotomy itself. And then typically I'll put a bit of Myostatin or Myocol inside the eye to bring the iris down. I think it's worthwhile just to make sure that the haptics are nicely in place and there's a gap there between the haptics and the IOL. Okay, so just a little bit, this is my only slide on capsulorhexis because I'm not going to really talk about the Z8 that much, but obviously we did a lot of work looking at the Z8 capsule itself, and the reason why Z8 gives you one of the best capsules, it's the only femtosecond laser that actually has a spiral pattern when it's basically creating. And if you look at this on SEM over here, this is the SEM basically from the Z8, and you can see a very smooth surface on this side, which is very similar to what we basically showed in our paper compared to a manual capsule, and this is basically from the Catalyst, and this is basically from the Victus. And the reason why you get these lines there itself is because the Victus and the Catalyst are firing in a vertical firing pattern. Okay, I mean, you can get some of our papers there, we explain this in a lot more detail on why you look at the capsule formation, and we show the strength of the capsule is pretty good with this firing system. This is my only slide on the Z8. Okay. So back to the case again. So we look at the case. So she's 6'6", basically unaided in the right eye. Left eye basically done on the YAG. You can see on the UBN the difference in the lens position here on the right side with the FEMTIS on this side over here and the posterior chamber intraocular lens over here itself. So after the YAG, of course, there was no more line. She never had a line on the right side, and she was obviously basically much happier with basically the result. And the other thing to look at is look at the effect of the tilt. Okay, or the lens, even though she's got a good best corrected visual acuity, and the tomography basically was showing only about 0.4 of adapter, you can see she's an induction of almost adapter of cylinder in the left eye and nothing basically, or basically 0.2 or 0.3 on the right side itself. And this is because obviously the lens is fixated on the right side on the anterior capsule, which is not basically on the left eye. And this is related to the size of the back. I mean, if anyone in this room puts their hands up and tell me they actually measure the backside, I'll be very impressed. Okay, because most of us basically don't, to be frank. And because we don't basically look at it, you just want to look at the density of the lens itself. So we're getting less basically lens-induced astigmatism as well. Okay, so I'll show you another case. So this is a 56-year-old male Singapore Airlines pilot. Okay, so obviously probably high visual demanding. So he was complaining of triplopia when he saw one of my colleagues. Best corrected visual acuity was good, 2+ nucleoscopic cataract. He was under the glaucoma service with bilateral ocular hypertension. He underwent cataract surgery by one of my colleagues. She put a CT Lucia lens in, so another good quality basic lens. She's a good cataract surgeon, completely routine, unaided visual acuity 6.7.5. 1 month, he came back at basically 3 months comparing basically halos at dim light and seeing a shade on the side of his vision. Now, of course, his vision is very perception. He's a pilot, right? So he's going to pick up these things quite easy itself. So she yagged him, okay? And then basically you can see his visual acuity, his best corrected is still pretty good. And then she waited on that find. He still basically complained of symptoms. This is basically post his YAG. And 12 months, he's still basically complaining of the same thing, shadowing in his vision on both sides. Corrected visual acuity is 6.6. So I just want to show you basically obviously what he had. Most of you probably know sitting in this room. Of course, he has negative and he has positive dysphotopsia. And this sort of picture over here describes to you basically what this whole phenomenon of negative dysphotopsia is itself. And basically it's a shadowing, typically in the temporal basically field where you get an arc, where you get a negative basically effect over here because you get a difference between the internal reflection of your light that's giving your photopic, your positive of a dysphotopsia versus your negative where you get a reflection coming around the outside of the lens and the area outside the lens where it's basically not basically being refracted. And that's why you get this negative black band in the field itself. Now over time, we know it can get better because of course you get fibrosis, right? So if you get fibrosis around that area, then basically this will seal off and then you won't get that internal reflection itself. But clearly in this situation, it didn't basically work itself. And normally it is one of the most common complications after what we consider perfect surgery. So you do a routine procedure, you got perfectly good capsulorhexis, and yet patients will still complain of this. And you can see the reduction goes from 15% normally about 1 month down to 3% at 1 year, because normally you'll basically get that fibrosis around that area itself. So, of course, that was the answer to his problem. He's got a basically dark shadow arc. He's got a well-centered IOL. But if you look at the picture over here and also on retroillumination, what you'll see is there's actually no fibrosis. And that's what I noticed when I first saw him. And I thought, okay, this is why you're basically getting this issue. But he's got a well-centered IOL and a good anterior capsular covering. I sent him basically for a UBM, and you can see there's a slight tilt basically after she did the YAG, and it basically brought a little bit of basically a bit of vitreous basically forward behind the lens itself. So the management, of course, we can do IOL reverse optic capture. You can actually rotate the lens, change the position from basically down to 3 to 9 o'clock. That's been shown to improve the negative dysphotopsia. Of course, you can do an IOL exchange and change the refractive media of the lens. So I basically will start with something the simplest thing. So I said to him, look, I'm not going to rotate the lens because he's already got an open capsule at the back. Let's basically just do a reverse basically optic capture for you and see how you basically go with the symptoms. And actually it was very simple to do because actually the lens just flipped out straight away as if it had been put in a week ago. And it was because he had no basically fibrosis there. So it basically came out quite easily, but he had a little bit of vitreous basically around the anterior edge, which I then took him back and I had to do a small anterior vitrectomy and clean that up. And his visual acuity basically improved on this side. And then we are left with, he said, okay, Jod, so what are you going to do on the other side now? And if you look in the literature, your options basically are to do a reverse optic capture as a primary procedure, okay, which you can certainly do. Okay, I said to him, why don't you try this lens instead? It works on a different technology. We can clip it basically to the anterior surface. Okay, so the lens basically is exactly the same. So I've already created the lens, the capsulotomy with basically the laser. Again, just basically checking with the haptics, with the positioning. I do this on every case. I think it's worthwhile just basically doing it as a routine thing to make sure you've got basically the flanges in the right position. It only takes a minute to do, to basically check. The lens nicely sits basically in this pocket. Make sure you've got a good amount of viscoelastic basically over here itself so it doesn't get caught up with the injector. Again, inject and then just wait and allow the memory of the lens to basically open up. So as the basically memory of the lens will basically open up. Again, exactly the same as before. I remove the viscoelastic basically from behind, put a little bit of viscoelastic on the surface, but I said if you're doing by manual, you can just stick an irrigation on there, and then go through your second paracentesis to basically just flip up your larger haptics on basically the surface to get your capture, and then basically make sure you then do the individual sides. And it's worthwhile doing the myostat. Sometimes when you flick up, one of the larger haptics can get caught basically on the side of the iris. And then if you look at the visual acuity result, okay, so pretty good on outcome-wise. So this is visual acuity and refraction and stability. And he told me it's like having a completely different procedure. And that's what he says. He's saying to me. He couldn't believe that he had the same surgery in basically both eyes. And he had the other eye done by a very good cataract surgeon. So in summary, dysphotopsia, which you have to realize is the most common cause of routine cataract surgery. So you've done a good job, everything's gone fine, and patients are still unhappy with the procedure itself. It's important to basically recognize and not to dismiss it. It's difficult to predict with current basically technology that's available in any company, on any platform, with any current PCIOL, who's basically going to get it. Clipping of the lens to the anterior capsule can avoid this problem, both with negative dysphotopsia and enhanced refractive optics, and reduce positive dysphotopsia itself, independent of capsulotomy variation, and it can improve your accuracy of your effective lens position. Thank you for your attention.